Hi, my name is Hannah Atman, and this is my head-to-toe assessment for my advanced health assessment class. So we're just going to go ahead and do a head-to-toe assessment, basic nursing assessment. A couple things to remember before you start. Every patient is different, so you're not going to do an assessment the same on every patient. You need to know why they're at the hospital, what surgeries they've had done. There's going to be different assessments you need to do based on their surgeries. You need to know what their what their assessment was for the previous nurse, and especially with neuro, you want to do a bedside assessment before the previous nurse leaves and you take over. Especially with neuro, because any neuro change can indicate like that the patient's bleeding or stroking again, and if you miss it and then just pass on to the next nurse that that's been like that, that's kind of on you if something happens. So first of all, get report, get everything you need to get together. Go into the patient's room. You want to do hand hygiene, and then do your bedside assessment with the previous nurse. Just get the basics out of the way so they can leave, and then you can come back and do your full head-to-toe assessment when you have time, because as a nurse you have to prioritize your time. So sometimes it's just a general survey, cross the room assessment, is the patient okay, before you can really go in there and listen and all that stuff. So first things first, let's do a set of vitals. And I forgot temperature probes. I forgot that.
You also forgot my consent.
Oh. Do you consent?
I guess.
And this is going to be my patient. And do you agree to have an assessment done by me?
I do agree.
Okay. So let's go ahead and get a blood pressure. And when you're doing the general survey or asking any questions to the patient, you can always make sure to ask them random questions like, what did you do before you retired? What do you do for a living? Where do you live? And that can really help you build rapport with the patient not only, but it also helps you know if they're oriented to person, place, time. So you don't just have to ask, do you know what city you're in? Do you know what year it is? If they can tell you basic things like that and have a conversation with you, then they're obviously oriented. But if they can't, then you need to ask those straightforward questions. Why are you in the hospital? What's your last name? What year is it? And what month is it? And all that stuff. Just take a blood pressure. So I got 110/64. Then you can just take a pulse. So I'm going to go grab my watch so that we can take a pulse with the watch. Even though my watch doesn't have a second hand on it, it's okay. Oh, I can do my pulse oximeter.
The white and the blue one's the new one.
I know what one's the new one. So we'll get oxygen sat and heart rate, so 98%, 64 beats per minute, perfect. And then we'll do a temperature. Under your tongue just for a second. Close your mouth. .7. And then obviously just count respirations. If you're gonna take a pulse from the radial pulse, you can just count their respirations while they're sitting there, so that you it doesn't change the respirations when you actually tell them you're gonna count their respirations. And sometimes, if they're connected to the monitor in the ICU, it'll tell you what their respirations are. But obviously, he's not in any distress. He's not air hungry, and he's not somnolent and lethargic, and possibly, breathing shallow and not breathing enough. He obviously is oxygenating himself. He's awake and alert. His eyes are open. He's tracking me. So you can use your nursing judgment, and just know that, just one, number like the respirations, you need to have more information than that. Even if he was only at like 10 respirations, that might be his normal. Okay, so we got a set of vitals. You're gonna just take a look at your patient when assessing them, see what if they appear their stated age. Sometimes patients, especially if they're chronically ill, they will look much older than their stated age. They will look chronically ill, and you can just say a chronically ill appearing 67-year-old or something, but he obviously looks his age 22. He looks mature, like developmentally mature, so that's good to know, and he's not in any distress. So when you're doing your bedside assessment, sometimes you don't have time to do the full head to toe assessment until after you've passed meds and all that stuff. But if you can look across the room and see that your patient's not in any distress, look at their vitals if you have that luxury, that's enough sometimes until you can get in the room and do the full head to toe. So he's not in any distress. Are you in any pain?
No.
Okay, so 0 out of 10 pain, that's the 5th vital sign, so you want to do that every time you take vitals, apparently. So after that, you're just going to look and make sure that they're groomed. What's their hygiene like? You can look under the patient's fingernails. I've found in the last couple months that, if the patient doesn't take care of their nails, that's a good indicator of how they take care of their whole body. Just look at, their hair, their just overall grooming status. Are their clothes clean? Do they smell? Anything like that. It can all come into the overall assessment of the patient. Okay, and then after that, we'll make sure we have a updated height and weight on the patient. We don't usually do this with a head-to-toe assessment in the hospital, but like in a clinic, you would ask what their height and weight is. And then go ahead and start with the assessment. So I always start my assessments with a neuro assessment because I think that that's the most important and most sensitive kind of assessment, especially for ICU patients who aren't in their normal state of mind a lot of the times. They might be sedated, they might be lethargic from pain meds, and they might have ICU delirium. So you just kind of want to get that baseline, especially if the previous nurse was here. So like I said before in this video, you want to do the neuro assessment with the nurse, especially if it's a stroke patient, if they've had a post-op brain surgery, anything related to neuro, just do a neuro. So obviously, I'm just going to ask the patient, do you know what year it is?
It is 2020.
Okay, and what's your last name?
Steele.
Okay, so why'd you come in the hospital?
Came into the hospital because my hamstring was hurt.
Okay. So person, and then what city are you in?
I'm in Great Falls, Montana.
So he's alert and oriented to person, place, time, and situation. So alert and oriented times 4. His eyes are open. I didn't need to pat him and wake him up. He's tracking me, and so that's all part of the level of consciousness assessment. After that, I always look at their pupils. You can look on your pen light. I think a lot of people sometimes don't understand how small 2 or 3 millimeters is, because a lot of people just chart 3 millimeters, but that's very, very small. Usually patients' pupils are more like 4 millimeters. So make sure that you know exactly how big their pupils are, and then just tell them to look at you. I'm going to look inside your pupils. Good. to react to light, and they're both about 4. So pupils are equally round and reactive to light is what you would chart. After that, I would always, especially if it's a stroke patient or anything, I might not do this to a patient who doesn't have a history of strokes or is just doesn't really fit the need to do this, but this is the full neuro assessment. Let's say if this patient has a history of strokes or if they're in the hospital for stroke or anything neuro related. So go ahead and give me a smile. Big smile when you see your teeth. Want to know any droops on each side, and if there is, you want to make sure that it's not worse with the bedside nurse that took care of them previously. Can you puff out your cheeks? Dog face. All of that, just make sure that they're symmetric. I don't do a whole cranial nerve assessment. I've never seen a nurse do a full cranial nerve assessment, but you can if you feel the need. I feel like 1, nurses don't have time, and 2, doctors usually do it, but they don't even do it sometimes. So I guess it just depends, but I personally have never done a cranial nerve assessment on a patient, so I'm not going to do it now. Go ahead and lift both arms up. Close your eyes. So you want to know any drift on the patient. If they can't lift both their arms up, you can lift it up for them and let go and see if, when gravity is eliminated, they can hold their arms up, but he has no drift. And I think it's important to tell them to close their eyes, because then you can really see if they have a drift there. So go ahead and pull me towards you and push me away from you. So his upper extremity strength is intact. Go ahead and squeeze my fingers. You would know if one arm was squeezing tighter than the other, or if one was weaker. You're going to go to the legs. Go ahead and lift your legs up. Close your eyes. Note any drift. It's kind of hard because he's sitting on a stool, but if they're laying in bed, this is much easier. Go ahead and lift your legs up and pull towards you. Pull me towards you. There you go, and push down. It's kind of hard because he's in that stool, but if they're in the hospital, just assess their lower extremities the way we did the upper extremities. See if they have any drift for their legs. It's kind of hard because if a patient truly did have a drift and they were weak, they probably don't have the core strength to lift their legs up anyways, so that one's kind of objective. And so just make sure you press, they try to press down with their ankles and pull you back up with their ankles just to see what their strength is. So his strength is 5 out of 5 on the upper extremities and 5 out of 5 on the lowers. If your patient had one arm or one leg that was less strong than the other, then you would just say like 4 out of 5 on the right arm, 5 out of 5 on the left arm, and then same for the lowers. So it just depends on your assessment. Make sure you kind of look at previous nurses' assessments, see what they've been charting. I think that neuro is very subjective. Like, a lot of people disagree with it. It's rare that you're going to get the same person to do say the exact same assessment, because it's just kind of gray. But that's why it's important to do the bedside neuro. So after the neuro, you just want to obviously take a full look at your patient. Just kind of know anything that really sticks out to you, but he's very healthy, so I'm just going to go ahead and go into my normal assessment. I normally feel their radial pulse first, and I look at the monitor if you have a monitor. You want to know what rhythm your patient is in. You want to know if they have a history of what they've been in or if it's new. You should print a strip, if you're in a critical care area and it's indicated, print a strip of the patient's heart rate, measure the PR interval, QRS complex, and actually interpret it, because sometimes just looking at it, you won't see the things that you would see if you actually sat down and measured it and stuff. So also feeling their pulse, you can feel if they're not in a rhythm that marches out. I found this significant when your patient is in AFib. It won't march out like this. It'll kind of be all over the place. So you can just see if your patient has a rhythm that marches out. His does. And if we had a monitor, we would see that he's in sinus rhythm. Take another look at their vitals, make sure they're stable, and then continue on with the assessment. I'm going to go ahead and listen to his heart and lungs. So for the lung assessment, I would just do, especially if they're bedridden and stuff, it's really hard to listen to the posterior lung fields and it's not really realistic. So I just go ahead and listen to the top portions and then the lower lobes. The book might say something different. I should probably look at that, but for heart assessing, auscultating the heart, you want to go ahead and listen to the aortic, which is second intercostal space, right midclavicular line, pulmonic, which is second intercostal space, left sternal border, not midclavicular line. And then you want to do the apex area, which, let's see, the tricuspid area is the fourth and fifth intercostal space at the left sternal border, I don't know, just at the sternal border. And then the mitral area is the fifth intercostal space, left sternal border, midclavicular line. So that's where I found that the heart rate is the strongest and you'll be able to auscultate it the best. Make sure that you note any rubs, gallops, murmurs. It's really hard to practice on really healthy patients. I think that the best way to learn how to listen to these is to actually listen to patients who do. I've found rubs and murmurs on patients and I didn't really know what it was because I'd never heard it before. So it's important to be assessing patients who are generally unhealthy and aren't completely healthy like this, because when they are healthy like this, you miss stuff because you know that they're healthy and what you're going to find almost. And then when you find an unhealthy patient and you find something that is not normal, that will help you become a better nurse, and you'll carry that with your assessments, going forward. So just go ahead and give them a listen. Take a deep breath for me. And then I just normally go right below here. Deep breath. And the right lobe the right lung has 3 lobes and the left lung has only 2, so it's important to be kind of listening a little bit more on this side because it's bigger and it might show more than the left lower lobes, I guess. So go ahead and listen to their heart rate. And when I do this, I also feel the radial pulse because it will help me try kind of find the heartbeat under there, especially if they have a big body habitus and they have a lot of body fat. It can be really hard to auscultate their heart, and so that I found can kind of help. So I'm going to go ahead and do that. Okay, so that sounds good. No, you don't have butterfly fat. If they've are a post-op heart and the heart surgeon puts chest tubes in that pericardial area, that will cause, I found for them to have a rub when you listen to them. A lot of young kids have murmurs and it's completely benign, but you just want to make sure that you chart it, and that's all you can do sometimes. After you assess that, make sure that their radial pulse looks good too. I go ahead and just do inspection of their extremities, feel for warmth if they're diaphoretic, or if they're cool and clammy, they might be getting shocky. But he's warm and dry to the touch, which is good. You want to check their capillary refill if it's less than 3 seconds, which it is. That's good to know because that means he's oxygenating his extremities. Smokers will a lot of time have clubbing on their nails and it'll be kind of curved like this. That's just an indicator of chronic hypoxia. And so that's just good to know for future reference, I guess. So check the other hand, just kind of feel, make sure, they're not clammy or anything like that. There would obviously be other signs if they were getting shocky though. Remember, it's all like the big picture. So if they were in the hospital bed, you'd have them lay down, but I'm not gonna have them do that. I know that his abdomen is symmetrical, it's soft. Is any of this hurting you? So you can just kind of lightly palpate the entire abdomen just to make sure that it's symmetrical and that it's non-tender to palpation. Nursing assessment doesn't really include palpating the actual organs. I've never seen that. And especially after like abdominal surgeries, they won't have bowel tones for a little bit, like a couple days. So you want to listen really intently if they've had abdominal surgery, because once they return their bowel sounds, they might be able to advance their diet, and you can kind of advocate for your patient because they'll be really miserable after a couple days of not being able to eat or drink anything. So go ahead and give each quadrant a listen. There's 4 quadrants, and then if you can't hear anything, truly, if you want to chart absent bowel tones, you have to sit there and listen for 5 minutes. So I don't know any nurse that has time to listen for 5 minutes, but that's what you're supposed to do. So I can hear he has active bowel tones. Something else to note with vitals is making sure, especially in the critical care patient, that they're peeing enough. Especially if they're borderline hypotensive, they might not be perfusing their kidneys, and you really want to know what their output has been, and you need to track it throughout your shift, because if they drop off their urine output, they might not be perfusing their kidneys, and you want to note the amount and kind of the color and the odor. That can all be an indicator of dehydration or lack of kidney perfusion. You want to know when the last time your patient had a bowel movement, and give them or hold their bowel meds according to that as well. So going forward, you just want to go down, like we already did the upper trunk, so let's do the lower trunk. Just go ahead and assess their legs, make sure that nothing points, sticks out to you. If your patient has had a heart cath and they did either a femoral or a radial approach, you want to assess the insertion site, make sure that there's no hematoma, and palpate it and make sure that it's nice and soft. You want to look at the dressing and make sure that there's no bleeding. You want to, and then you want to check the vascularity distal to that insertion area. So usually it's the femoral artery that they go in through. So look at that insertion site, and then you have to check the perfusion distal. So distally, you check perfusion by checking their pulses, first of all. So I'm going to palpate for the DP pulse. I already feel it. If the patient has a hard pulse to find, I would just mark that with a Sharpie, that area. And then his PT pulse. Let's see if I can find it. Go ahead and relax really. And I feel his DP pulse. So we have pulses, and we want to make sure that the foot isn't like cold or white. You want to make sure that it's warm and that its cap refill is good. You can also do the 5 P's of perfusion: pain, pallor, pulselessness, paresthesia, and paralysis. So do you have any pain in here?
I do not.
Okay, so then he has his pulses, pallor, he has good color, so that's good, and then paralysis, can you wiggle your toes? And then paresthesia, can you feel this?
Yes, I can.
Okay, so that's pretty much how you assess that. You want to, especially if they're like immediate post-op, you need to be checking that every 15 minutes for like 2 hours. Same on this foot, and check the perfusion and their pulses. Sometimes you literally just can't feel the pulse because their body habitus is so big, And if they have peripheral vascular disease, they might, or diabetes, or they just don't take care of themselves, they might have hardened skin down there, and it just makes it really hard. You just need to know why they're in the hospital and go from there. It's not something, critical if they can still move their feet and, you see that they have cap refill, obviously that they're perfusing. So, but in a post-calf patient, you definitely need to feel those pulses, and if you can't, you need to Doppler them. So, after that, you just make sure that your patient is comfortable laying in bed, if they need anything, and then go ahead and go chart that assessment. So, thank you for watching.